الناس بتحبها جدا جدا، ويعني وبتدي ريزلتس لينا ككلينيشنز رائعه في معظم الاحيان. MRI of NeuroImmune disorders in children. دكتوره رانيا.
Okay. First of all, I would like to thank Dr. Marianne Yusri for inviting me for this very scientific meeting, and I'm getting benefit from the discussion of you professors, adding to my experience in pediatric neurology. I would like to thank you, Professor Murtada Shabrawi, Dr. Rania, Muhammad Omar. Thank you a lot. Dr. Lubna Mansour, I'm honored to be here with you. This is a very long and very important topic to discuss, but I would like to get it more comprehensive, okay? So first we like to say that neuroimmune disorder are a complex group of demyelinating, inflammatory, para-infectious, and post-infectious disorder with heterogeneous pathophysiological mechanism and clinical manifestation associated with fundamental derangement in the immune regulation. The diagnosis in patients with this disorder relies on the clinical feature of the acquired neuroinflammation. In today's practice, the prompt diagnosis and the immunomodulatory therapy have improved the clinical outcome for the neuroimmune disorder. We will begin by the relapsing demyelinating syndromes. So what are the relapsing demyelinating syndrome? We have the MS, the ADEM, the aquaporin 4 antibody-associated neuromyelitis optica spectrum, and the myelin, the anti-MOG-antibody related disease, and the antibody-negative demyelinating syndrome. So now we are in the era of the antibody and serology and genetics. So we will get all this lecture from this perspective. The relapsing demyelinating syndromes, they are overlap in the clinical presentation, so there is reliance on the magnetic resonance imaging to satisfy the criteria for treatment initiation and optimization. First, we have to say what is the optimal MRI protocol for any demyelinating, suspecting acquired demyelination. We have to do a brain plus whole spine with contrast. Brain with dual inversion recovery. What is dual inversion recovery? This is the picture of the dual inversion recovery. You can see that the white matter is very dark in color. So when there is a lesion inside, it will be hyper intense. You can see it. So it magnifies the white matter lesion. This is a new protocol, dual inversion recovery, and also the non-sagittal flare. And then the orbit. For the orbit, we will do a high resolution contrast fed suppression to diagnose optic neuritis. Okay. Then the MRS is used for differential diagnosis because there is overlap in the imaging, and then the DTI for the assessment of the involved tracks. The MRS is the most common one of them, and we will use the revised McDonald criteria 2017 with what is the difference between the pediatric MS and the MS in adult. The higher lesion burden at presentation, the brainstem infratentorial lesion are more common in pediatric MS. The demyelinating lesions tend to be larger in size. Then we have the revised McDonald criteria 2017 with the dissemination in space and the dissemination in time. The MS will have a discrete ovoid lesion, periventricular, juxtacortical. Also in the children, it is common in the infratentorial brainstem cerebellar, and there is in the spinal cord, it is focal, peripheral and focal, okay? Cervical more than thoracic, and along the lateral and the dorsal column. Also the optic nerve, we have short segment and unilateral. So this is a case with MS coming to us. You can see here there is a tumefactive lesion. The tumefactive lesion will have on flare, there is a semilunar hyperintense rim. This is characteristic for the tumefactive demyelinating lesion, and there is involvement of the corpus callosum. And then this is tumefactive, يعني بيحصل فيها cavitation. This is the area of the cavitation. Okay, because it is low in T1, and also in flare there is low signal, meaning that it is old. and then you can see that there is here semilunar enhancement. So in incomplete ring, this is very important. Incomplete ring, and the incomplete ring is toward the cerebrum, not to the calvarium. So it is defective toward the calvarium. So this is characteristic for the demyelinating tumefactive lesion, and also is very important the choline, because it is an acute lesion. The choline create ratio is very high, and the lactate is very high because there is anaerobic glycolysis, meaning that this is an active lesion. Then we have the neuromyelitis optica spectrum. The clue of MRI is paramedian lesion. Paramedian around, surrounding here in the hypothalamus. This is the area where you can find that there is neuromyelitis optica lesion, paramedian. And you can see here, periaqueductal, and in the area rostrum, in the medulla. And then it is common with longitudinally extensive transverse myelitis. What is longitudinally extensive transverse myelitis? Transverse myelitis is diagnosed as a 3 vertebra and involvement of more than 2/3 of the cord, large segment of the cord. But if it is more than 3 and longitudinal, getting in the cervical, in the dorsal, this is called longitudinally extensive transverse myelitis. It's very common nowadays, maybe due to the autoimmune demyelination and the COVID. It's very common. All of the cases coming with longitudinally extensive transverse myelitis, and even hemorrhage in the cord, which is not seen before. Also, you can see here, what is the optic nerve involvement in neuromyelitis? It is bilateral and posterior predominance with chiasmal involvement. You can see here, there is bilateral. This is a fat suppression post-contrast MRI of the orbit. You can see there is enhancement in the optic nerve, bilateral and symmetrical. And if it is, there is posterior involvement, it's more with the neuromyelitis optica. Okay. Then here an example, this is a case that come to us in Abu Rish. Here you can see that we have seen it is paramedian lesion. Paramedian, it is in the floor of the fourth ventricle, so this is pathognomonic for neuromyelitis optica, and there is longitudinally extensive transverse myelitis. You can see that there is cervical lesion and there is dorsal lesions, and also all these segment is involved, and this is the axial cut. You can see that this is involving more than 2/3 of the cord, and also it is central. So neuromyelitis optica tend to be central involvement. Then we have the MOG-related antibody disease, the MOG brain, multifocal, deep white matter, cortical, subcortical, also in the brain stem. So infratentorial lesions are very common. Okay, you can see here it is subcortical. Okay, and infratentorial lesions are seen. Very important to note that there is common, there are multifocal lesions, okay? Longitudinally extensive transverse myelitis also seen in MOG-antibody, related antibody disease, but more than the short segment myelitis. The conus involvement is very common, okay? The optic nerve tend to be anterior, bilateral, and anterior predominance, okay? Because neuromyelitis is posterior more, but also it could be unilateral. Here you can see there is longitudinally extensive transverse myelitis in the cord, okay? And characteristically it can involve the gray matter, like you can see the H-shaped gray matter lesion like this, could be seen in the MOG-related disease. Here, this is another case of MOG with subcortical white matter lesion, multifocal, and there is punctate enhancement, infratentorial lesion very common, okay, and punctate enhancement again. Then this is a case of MOG-related antibody disease with patchy areas of the cerebellum, in the cerebellum, and also here you can see that there is a deep white matter lesion, subcortical white matter lesion. Then on MRS there is increased choline create ratio, denoting that there is active demyelination. And here you can see that there is, the conus is enlarged. So the conus is enlarged, it may point to that this is maybe a MOG antibody related disease. So when you find the conus, you may suggest that this is maybe a MOG related. Then we have the ADEM. It is a multifocal with deep gray and cortical involvement and variable enhancement. Okay, the course is less favorable than the MOG positive lesions. Okay, the cord less common than the MOG, so the MOG is more common, and the neuromyelitis optica, cord involvement is more common in them. But here, if there is a cord, it will be longitudinally extensive transverse myelitis pattern. You can see here, this is a case of, we will see the 3 pattern. You can see here that this is a paramedian lesions. This is as an MS, because these are perpendicular to the surface of the ventricle, اللي هو Dawson fingers. So this is an MS, okay, and this is the confluent periventricular lesion. And you here see that there is focal lesions. Short segment focal lesion usually involve the posterior and the lateral segment, the lateral column. Here you can see that this is posterior. Okay, sometimes it is lateral. It is patchy and coming from the posterior aspect of the cord. Patchy, short segment coming from the posterior aspect. This is characteristic for MS. Okay, then we have this case with MOG related disease, supra and infratentorial lesion with punctate enhancement, and also multifocal in this case. But here you can see that the gray matter is seen. So this is seen also in MOG. And then we have here the neuromyelitis optica with the area of prostroma is involved here. Okay, related dorsal aspect of the medulla. And then we have here the longitudinally extensive or the transverse myelitis. And here it is a central pattern of involvement. Okay, so this is to compare how to diagnose them on imaging. So optic nerve focal short segment unilateral MS. Long bilateral, no optic chiasm, it is MOG related. Optic chiasm, neuromyelitis optica, MS. Then we have the spinal cord, focal short eccentric MS. Longitudinally extensive, it may be MOG related or neuromyelitis optica. If it is central, it is neuromyelitis optica. Okay, if the gray matter is apparent, it may be a MOG related disease. Then we have here how to diagnose them on imaging. So the imaging, the brain and spinal MRI. So if there is, according to the revised McDonald criteria 2017, it is pediatric MS. If it is suggestive of ADEM, you will do a MOG-antibody, yes, MOG-antibody-associated disease. Suggestive on neuromyelitis optica, make the both antibodies. If yes, it is a MOG. If no, if yes, it is aquaporin. And then if no, there is a seronegative relapsing demyelinating with no antibody that can be found. Then this is an example of what this MS, because it is perpendicular to the surface of the ventricle. So these MS lesion, so are perpendicular to the surface of the ventricle. Okay, callososeptal and perpendicular to Dawson finger. Then we have this case. This is what? This is neuromyelitis optica, because this is the paramedian lesion and hypothalamic and periaqueductal lesions. Okay. Then we have the this lesion. You can use, this is MOG related disease. Okay, and this is longitudinally extensive transverse myelitis. And this is what? This is limbic encephalitis. We will discuss the limbic encephalitis later on. It is a type of autoimmune related disease. Other neuroimmune disease, we have the anti-NM autoimmune encephalitis, very large. Now we diagnose autoimmune encephalitis very frequently. Yes, Dr. Marian. Okay, they are very common, and so we have to know what are the clinical and the radiological presentation. The leading cause of autoimmune encephalitis is the anti-NMDAR encephalitis. MRI is most commonly normal. So it does not rule. If the MRI is normal, 65% are with an MRI normal. But if there is the limbic encephalitis pattern, like the last case I found, then we have the striatal pattern. What is that? Striatal encephalitis meaning that it involves the corpus striatum, the caudate and the vitamina of the lentiform nucleus in a bilateral symmetric pattern. We have the brainstem. Only in the brainstem, it can come in the brainstem, and also we have the cerebralitis, and we have the cortical involvement, very important, but with no diffusion restriction. So here the clue is the no diffusion restriction, because you may find that when you find that there is no diffusion restriction, don't diagnose autoimmune encephalitis. So no diffusion restriction on MRI is very important, but be sure that this is coming in the acute case. Maybe it is a chronic case. The diffusion restriction appear in the acute within 2 to 7 days from the beginning of the disease. So maybe it is a chronic, okay? But if it's acute presentation with no diffusion restriction, it is autoimmune encephalitis. Differential diagnosed herpetic encephalitis. Also, the herpetic encephalitis does not involve the basal ganglia. And here you can see in the autoimmune, it is bilateral and is symmetric pattern. Very important. It is symmetric. Here there is no involvement of the basal ganglia. There is hemorrhage and there is enhancement in herpetic encephalitis. Here example, we will practice. This is limbic encephalitis, involve the limbic system, okay? Then we have here, you can see that there is corpus striatum involvement, bilateral and symmetric pattern. So, okay? And then we have here limbic, okay, system involved, okay, again, okay? And here, this area also is common in the limbic, it is part of the limbic system, so it is involved in autoimmune limbic encephalitis, but with no diffusion restriction. So the clue is the no diffusion restriction in the MRI images, okay? Then, this case, it is a herpetic, post-herpetic disease. You can see here there is gliosis, but also there is abnormal signal in the white matter. This is autoimmune encephalitis with leukoencephalopathy in the white matter. So you're very important to do a follow-up. Yes, you do initial when the patient is herpetic, and you do several follow-up to see if there is something new has happened. If there is something new, you may suspect autoimmune, like the case that you, yeah. And if it is normal, even if it is normal, also it could be autoimmune encephalitis because 60% pass with normal MRI. Okay. Autoimmune encephalitis with cerebralitis. This is a case coming also to Abu Rish. Here you can see that there is an abnormal signal in the white matter of the cerebellum, and is rather asymmetry, and there is no diffusion restriction. Here you can see no diffusion restriction. So this is an autoimmune encephalitis, a cerebralitis type. Then we have the genetic triggers of inflammation. We have the primary, an example for the primary HLH, the genetic one. This coming to our department, you can see there is subcortical large white matter lesion. And due to the disruption of the blood-brain barrier, you may find hemorrhage. They may have micro hemorrhage inside. And also due to the T-cell infiltration, they may have abnormal, like pseudotumor or lesions enhancing inside the brain, okay? And they are not tumors, like in this case. You can see here there is microhemorrhage in T2. Also here you can see that there is microhemorrhage, there is hemorrhage in T2. And then we have the pseudotumor. This is due to T-cell infiltration of the and the disruption of the blood-brain barrier will lead to like an tumor, and also it is known that it may have infiltration of the common to have infiltration of the meninges. So in this case, they suspect that this is maybe a tumor, but it wasn't. It was a pseudotumor and regressed over time with immunosuppressant treatment. You can see here there is this spectrum is, you cannot read it because there is hemorrhage inside the lesion, so it's not indicated to do MRS for hemorrhagic lesions. Then this is the disease albinism with genetic primary HLH. Then this is concerning the cases coming before the era of the diagnosis of the COVID in the end of 2019. We have Dr. Marianne know this. We have a large number of acute necrotizing encephalopathy lesions cases. They came, we collect them. We don't know what is that. But after that, and I contact Dr. Marianne, and she said, we don't know what is that, because this is with influenza. Japanese encephalitis was diagnosed before with influenza virus, but all of them were negative for influenza, and this is before knowing that there is COVID. So we published this one, and we have a large number, maybe 30, coming within 3 months. It was very weird. We published them, and we did for them MRI and MRS and diffusion and SWI, and you can see here, this is one of them, of these cases. You can see there is hemorrhage inside the thalamus, bilateral and symmetric, and at first it was very weird for us. We do MRA, MRV to exclude local causes, and then we suspect that this is Japanese encephalitis, so we ask for influenza, if it is influenza, and Dr. Marianne responded, no, it's not influenza, we don't know what it does. And then it turned out all of these were COVID cases and undiagnosed. This is also a case of a necrotizing encephalopathy. ممكن اخد 3 دقايق كمان؟ اوكي. Okay. Then we have an AHLE, acute hemorrhagic leukoencephalitis. Also, this is case diagnosed in Abu Rish. There is massive hemorrhage and non-enhancing, multiple lesions in the MRI. Okay, and then the follow-up after Dr. Marianne contacted me, and she did diagnose it as an autoimmune lesions and give the patient treatment, and the patient improved on after 2 weeks it improved. So this is an acute hemorrhagic leukoencephalitis, or the so-known AHLE. Then we have the acute leukoencephalopathy with restricted diffusion, which is very important to note because we know now that the restricted diffusion is not common in autoimmune diseases, okay? And maybe it is, when it comes in a mixed pattern, facilitated with restricted lesions in the same pattern. We know no true restriction, but in this, they found this is a late diagnosed disease, alert acute leukoencephalopathy with restricted diffusion, which is autoimmune too. So now we are cautious before saying that this is not autoimmune. We usually used to diagnose it as a metabolic inborn error, a mitochondrial, but it turns not, it is alert. Post-COVID immune-mediated non-specific encephalopathy, ADEM, Guillain-Barré, ANE, and limbic encephalitis, cortical lesion, cerebralitis. This is case of post-COVID. You can see there is abnormal signal in the right cerebral peduncle. Then we have here the Guillain-Barré with the enhancement of the coda equina nerve root. It may be partial, complete, or total, anterior or posterior. Then what is the differential diagnosis? We have here the toxic demyelination, like the hypernatremic injury. It's bilateral symmetrical, but there is microhemorrhage and restricted diffusion of the white matter. Central pontine myelinolysis, it's characteristically, you can see that the corticospinal tracts are relatively spared, so this is characteristic for the central pontine myelinolysis. Also in this case, there is the corticospinal tract are spared. Then we have the gliomatous cerebri, which is very important as a differential diagnosis, and the importance is the enlargement. When you find marked enlargement with relative low T2 and no diffusion restriction and very considerable mass effect, it may be a gliomatous cerebri, and it is a very insidious onset, so you have to do more follow-up and MRS to diagnose the myoinostall peak. Okay. Then we have the FACI in the neurofibromatosis type 1, the foci of abnormal signal intensity. Also, it is patchy, so you have to check the patient if he has cafe au lait patches. Here you can see that this is neuroimmune disorder with encephalopathy. MRI abnormality. If there is limbic, consider limbic encephalitis. Cortical, autoimmune encephalitis, MOG-antibody associated disease, CNS vasculitis. Basal and thalamic abnormality, mitochondrial, acute ANE, thiamine transporter mutation, very important. But the thiamine, there is a diffusion restriction in the thiamine. Okay. Autoimmune encephalitis ما فيهوش no diffusion restriction. White matter بقى دي احنا شرحناها في الأول. Okay. Thank you.
رانيا ثانك يو. بصراحه انا كنت عايز المحاضره تطول عنك، انا كان نفسي بصراحه يعني. بص ده راي الكل يعني. ثانك يو. السلايدز بيوتيفول. الكواليتي بتاعتها كمان حلوه. بتهيألي الهدوء اللي كان في القاعه ياكد لحضرتك مدى استمتاع الناس كلها. وانا ادفانس بس عملوا لي ايوه انا كنت بحتاس في دي، هي دي فرقها دي عن ايوه ايه ده. فيعني بجد ثانك يو فيري ماتش. يعني بتهيألي حضرتك محتاجه تسقيفه ثانيه على المحاضره الجميله.
ربنا يخليك.
اتفضل يا حضرتك مرتضى.
شكرا دكتور رانيا على المحاضره القيمه جدا جدا دي. احنا ولاء موجوده هنا، هي احنا وي ونت ان اور ديبارتمنت ان ا ديسكشن يا دكتوره رانيا، هل العيان اللي احنا شاكين عنده نيوروديجنريتيف ديزيز نطلب له MRI برين لوحدها ولا MRI سباينال كورد ولا الاثنين بالمره؟ يعني وات دو يو ثينك والنيورولوجيست رايهم ايه؟ لان العيان بنبعته يعمل MRI برين بعدين يطلع يقول لك لا يعمل كمان MRI سباين وتخديره ومش تخديره وكلام. ايه راي حضرتك؟ نعم
الديمايلينيشن
يعني نيورولوجيكال ديزيز، انا ما اعرفش في نيورولوجي بس اهي ولاء موجوده هنا اهو. وعيان طلبنا له مره MRI برين بعد كده MR سباينال كورد وتخديره ومش تخديره وتكاليف وكلام من ده.
No, if you have cerebral signs or manifestations, you have seizures, you have mental subnormality, you have.
لا الصوت مش واضح يا لبنى.
الصوت مش واضح؟
ميكروفونك مش لا الميكروفون مش
يعني if you have cerebral manifestations, you should go for MRI brain. Let's say عنده seizures, عنده deterioration of speech, you have cerebral symptoms. Okay, if you have yes spinal cord manifestations, you have let's say cervical level or on lumbar level. It depends on which level, because يعني مش هينفع نقول MRI brain and whole spine. You should have what we call anatomical localization. You have localization of your child, and then the investigation properly fits to your localization. If it's on the cervical level, you brain and cervical spinal cord. If it's lower level, so if you both together, because some cases have both, it's cranial and then or MRI brain and then on the lumbar region. It depends on your localization. For immune mediated, NMO, you have to check both. For ADEM, you have to check both. Okay?
Either you are suspecting acquired demyelination and not relapsing, you do a whole brain
yes.
and
yes.
also optic fat suppression. But if you are not suspecting anything to the spinal, begin with MRI brain because they are very expensive.
Thank you. طبعا الشكر لسه موصول طبعا، يعني استاذتنا دكتوره امنيه انا مش شايفها، دكتوره امنيه عفيفي، فبرضه الشكر موصول ليها ومباركه ليها هي دكتوره السباعي.